Okay, today we'll talk about salivary glands. We'll talk about anatomy, physiology, disorders of the salivary gland, meaning functional disorders, inflammatory, and neoplastic. Starting off with the anatomy. Salivary glands are apocrine glands. We have the parotid gland, which is the largest gland. It usually mostly secretes serous secretions, whereas the submandibular gland is a little bit smaller. It has, so it's the medium sized gland. It has both serous and mucus secretions. And then sublingual glands, which are smaller and they are mostly have mucus secretions, and then the minor salivary glands they secrete mucus. So the smaller the salivary gland, the more mucinous its secretions become, and the larger the gland, the more serous its secretions. The anatomy of the salivary glands is very important to notice that the parotid gland, it's anterior to the ear, and the anterior to the surface of the jaw at the angle of the mandible. And that's the end of it. And then you have the Stenson's duct, which is the parotid gland duct. It opens against the second premolar, and usually you can see the opening if you do a bimanual examination and you look at the inner aspect of the cheek. You will be able to see the opening of the parotid gland, and you can, if you squeeze it, you can see the secretions coming out of it. Then you have the submandibular gland. Again, the submandibular gland is a little bit smaller than the parotid gland. As we said, the secretions of the submandibular gland are more mucinous than the parotid, but they're still more serous than the sublingual or in the minor ducts. Salivary glands. The duct of the submandibular gland is called the Wharton's duct. So Stenson's duct is the duct of the parotid, and then the Wharton's duct is the duct of the submandibular. The submandibular gland has a longer duct and a smaller duct, and this will be more. The importance of this will be more evident as we talk later on about stones. Then you have the sublingual glands, and then the minor salivary glands. They're distributed throughout your tongue and the pharynx, and they secrete more mucinous secretions, and these help lubricate the food as you swallow. Really, it's important to notice the relation between the parotid gland and the facial nerve and other nerves. Like the great auricular nerve is the lies anterior, like just behind it, and it goes anterior to the ear. It's usually more superficial, and this is a sensory nerve. We can try to save it during surgery, but sometimes we need to cut it, which is okay. Now the facial nerve. It really is important to notice the relationship between the parotid gland and the facial nerve. The facial nerve and the branches of the facial nerves, they are embedded between the superficial and the deep part of the parotid gland. And this is especially important when we do parotidectomy, when we remove part of the parotid. If we take out the whole parotid, the chances of injuring the facial nerve are high. If we do superficial parotidectomy, we should not injure the facial nerve because we're right on top of it. We don't go underneath it. Remember the branches of the facial nerve. They're with a you can remember them with this sentence to Zimbabwe Zimbabwe by motorcycle. You can do it's temporal, zygomatic, buccal, mandibular, and cervical. So these are the branches of the facial nerve. Just remember them. So like if you look here, the parotid gland that's the superficial part of the parotid is on top of the facial nerve. Then when you take it out, you can see the deep part of the parotid. The facial nerve is on top of it. Also, really important is to notice that you have the facial artery and vein. The facial vein. A lot of times you need is just to remember this facial vein. Sometimes it's important when you gain access. When we do our surgeries for parotidectomy, we usually do a lazy S incision, meaning we go from anterior to the ear, and then you go behind to the angle of the mandible, and then you do a low S at the lower aspect of the mandible, so it becomes a lazy S shaped incision. Physiology. Salivary glands, they produce mostly saliva, right? So, and then remember the saliva has amylase. So when you have high amylase level, that could be either from the salivary origin or from the pancreas. That's why when we try to differentiate between the amylase and the pancreatic and the salivary amylase as a source of hyperamylasemia, we can send the P amylase, which is pancreatic, and then the S amylase is the salivary, and we can differentiate between both of them. We usually don't routinely do that. We depend on also doing other pancreatic enzymes such as the lipase, and in order to differentiate between salivary causes of hyperamylasemia rather than the pancreatic causes. Secretory units in each of these glands are composed of the acinus. The acinus is the gland basically. It produces the secretions. It has some secretory granules, and these secretory granules would have either amylase or mucin, depending on the type of the secretions. We have the myoepithelial cells. These are needed in order to empty the secretions. Intercalated ducts, they connect these secretory units together in order to have all the secretions dumped into the major duct, and then the duct would secrete them into your target organ. And then striated and excretory ducts. The excretory ducts, again, the major duct of the parotid is Stenson's duct, and Wharton's duct of the submandibular. The acinus contains secretory granules. As we said, these secretory granules, the secretions could be either amylase, in case that the secretion is going to be serous, or mucin in mucus producing acini. Especially remember, as we said, the larger the gland, the more serous the secretions. The smaller the gland, the more mucinous the secretions. We have about 600 to 1200 ml of saliva that are produced every day. 45 to 60% of these are secreted from the submandibular, and then 30 to 45% from the parotid, and 5% from the sublingual. We have parasympathetic stimulation that stimulates the production of saliva, and any denervation leads to atrophy of the gland and xerostomia. Sympathetic stimulation causes the scant saliva production, so it usually causes more mucinous and more viscous secretion when you have sympathetic stimulation. Okay, that's why when you're afraid, when you're scared, الواحد بيحكي نشف ريقي, right? So this indicates that you have sympathetic stimulation, and that's why you have decreased secretions of the saliva, and it's more mucinous and more viscous than serous. Now, salivary gland diseases, we'll talk about functional, obstructive, neoplastic, and neoplastic disorders. Let's start off by functional disorders. Xerostomia, meaning that you have decreased production of saliva. This can be related to multiple underlying causes. Could be related to medications, radiation. Patients who take radioactive iodine, they especially have xerostomia. They can have, it could be related to trauma of the parotid. Denervation, meaning, as we said, if we have parasympathetic denervation, then we wouldn't have enough or adequate secretion of the saliva. And then post-surgical, after intervening or doing resections. Salivary, meaning as the opposite, meaning increase in salivary flow. Sometimes it's related to mental retardation, mercury poisoning medications, also psychological, and rabies. All of these they lead to increased production of the saliva. Could be related to increased parasympathetic stimulation. Now we have mucoceles and ranulas. These are basically cystic lesions that are filled with saliva inside. They're related to trauma mostly. They could be um, due to obstruction and disruption of the ducts or the intercalated ducts. They usually are treated with excision, and they're mostly or like most likely to be present in the lower lips rather than the upper lips. This is a picture of a ranula, as you can see. It's a cystic lesion. It's a mucocele, meaning that it has mucus or saliva within. These are usually taken out by excisions, surgical excision, and then afterwards there's still some risk of recurrence, but mostly they do well. Second type of disorders, they're obstructive disorders. First thing we have is sialolithiasis, which are stones of the salivary gland duct. It can occur either in the parotid or the submandibular gland. More common in the submandibular because of the longer duct and smaller size duct, as we said earlier. They have more viscous secretions as well. Remember, it's more mucinous, and they have more calcium and phosphate within these secretions. So they're more prone to develop stones within the submandibular duct gland. The gland duct, sorry. Obstruction, once you have obstruction, you have secretions that are not capable of emptying. So you would have increased pressure, and then that would cause swelling and acute pain. Usually the pain is more aggravated by the side of like lemon or anything that would enhance saliva production, right? So if you think about anything sour right now, you will have increased salivation. That's the cephalic phase, right? So once you think of that, or once you see lemon, that would increase the secretions, and now you have obstruction, you have increased secretions, so you will have increased pressure within the gland and within the duct prior to the level of the obstruction, and that would cause acute pain. They usually resolve after a while because of the reabsorption. And then the stones might move. So if they move, and they would decrease the amount of obstruction. So then you want to have relief of the contents. But then it moves again, and it causes the obstruction again, and that would cause swelling and pain as well. So you would have intermittent swelling and pain. How do we diagnose it? Basically on history and physical examination, and then we can move to imaging studies. The imaging study is cyanogram. Basically, we cannulate the opening of the duct, and then we inject contrast, and we see the duct, or we we give them the and then we look at the imaging. The treatment is by intraoral cyalolithotomy. This is especially valid for parotid ducts because they're wider and they're shorter. So you can just go there and then open the duct and extract the stone. Most likely for submandibular glands, the stone is impacted within the duct itself. So a lot of times you end up doing resection or cyanectomy rather than cyalolithotomy. Now we have cystoscopes right now, and certain especially OMFS or head and neck surgeons, they can access the opening of the duct, and then they can go with a scope and retrieve the stone. This would be very helpful in cases where you have the stone impacted within. So this is a picture of the cyanogram, and then if you see the red arrow, it points at a filling defect. So before and afterwards, you have this whitish contrast material, and then this is the stone. The stone is black, and then you don't have any contrast passing within that point because you have the stone. So it's a filling defect. Next, we have inflammatory disorders, infectious disorders such as viral or mumps, parotitis. This used to be very common before. Now, with the availability of the MMR vaccine and the widespread of the usage of the MMR vaccine, we rarely see viral mumps, parotitis. Bacterial. This is especially important in elderly and dehydrated patients. It happens usually. Staph aureus is the culprit microorganism, and sometimes they can even develop an abscess. If they develop an abscess, we need to do an incision and drainage in addition to the antibiotics treatment. Antibiotic treatment should cover Staph aureus. They're mostly MSSA, meaning methicillin sensitive Staph aureus, but occasionally they can be MRSA, but mostly that's MSSA. Physical examination for acute bacterial parotitis. You would see purulent discharge from the duct opening upon milking it. So you do bimanual examination. You're opening with a tongue depressor. You open the or with your hands, with your fingers. You would open the mouth, and you would milk from the outside the duct. And as you milk the duct, you would see again the purulent discharge from the opening of the duct. So the diagnosis is basically based on history and physical examination. This is a picture showing purulent discharge from the duct, as you can see it, right? It's purulent discharge. Now, going into neoplastic disorders, we have the neoplastic lesions of the salivary glands. They're practically not common. They're rare. There's around two in every amongst every 100,000 in the U.S., making it about 1% of head and neck tumors. There are 80% of these neoplastic disorders. Again, remember, neoplasm does not mean cancer. Neoplasm includes both benign and malignant tumors. So 80% of neoplasms are in the parotid gland, and 10 to 15% they arise from the submandibular glands. Parotid tumors are more likely to be benign, and then the smaller the gland is, the higher the risk of the tumor being malignant. So almost half of submandibular tumors and the majority of sublingual gland tumors are malignant. Benign tumors, we have pleomorphic adenoma, we have papillary cystadenoma lymphomatosum, which is Warthin's tumors. We have basal cell adenomas and then oncocytoma. The most common and most important, there are the pleomorphic adenoma and the papillary cystadenomas, or Warthin's tumor. If you get to choose, which one would you choose? Warthin's tumor. Warthin's tumor, they have lower recurrence rates and they're benign. They don't have malignant transformation potential. Pleomorphic adenomas, there are 90% of the cases, these tumors, they affect the parotid gland. They're mostly present in the lower pole of the superficial lobe of the gland, so this is a good thing. They're in the superficial part. So basically, treatment can be related, restricted to superficial parotidectomy, but not complete or total parotidectomy, and this would help us save the facial nerve. Females are more likely to be affected than males, usually between 4th and 6th decade. Features are basically slowly growing, painless, solitary, firm, smooth, and mobile mass. So basically on physical examination, right? So patient comes in, they're saying, oh, well, I have this swelling in my face. It's growing slowly. If you ask them if it's painless or painful, they tell you there's no pain. Most likely it's only at that place. It's seldom would be bilateral. It's usually smooth and mobile when you examine it. So it's important to do your physical examination. And there's no facial nerve paralysis. It's very important to document facial nerve examination prior to doing any surgeries on these patients. You have to document. You have to make sure that you mention the detailed examination, not only to determine whether there's malignant potential, but also for medical legal issues. That way, if the patient already had facial nerve paralysis preoperatively, but you didn't document it, then postoperatively, the patient can come and say, well, I was perfectly okay. This is just related, this is a complication from your surgery, and then you can get into a dilemma. So always document the facial nerve examination prior to surgery. Um, Imaging studies, basically you do CT scan and ultrasound. They're helpful. And then you can see the features on that. FNA is helpful for diagnosis. And once you reach the diagnosis, the treatment is surgical excision. Basically superficial paroidectomy. As we said, mostly these are present in the superficial parotid. Now, radiotherapy, this could be helpful because of the high chance of recurrence, okay, and then also the ability to regenerate into malignancy. So you can radiate that area. This is a picture of this tumor. Sometimes they are not as big as this one, but you can see this is a large tumor. It's at the lower pole of the parotid, as we said, the part of the parotid which is against the angle of the mandible. This is a CT scan showing the tumor as well, as you can see it. Warthin's tumor, it's a benign tumor as well. It's mainly in the parotid gland, and again, the patients here are usually older than the patients presenting with pleomorphic adenoma. They're usually over 60 years of age, whereas though the other patients between the fourth and sixth decade, meaning 30s to 50s. Male to female ratio. So this one is more common in males. That one was more common in females. This is more the Warthin's tumor is more likely to be bilateral than pleomorphic adenomas, but still mostly unilateral. It usually presents also with painless lesion unless they become infected, and treatment is surgical excision, and those do not have malignant potential. Malignant tumors of the salivary glands. Mucoepidermoid carcinoma is the most common malignant tumor of the salivary gland. This is a bad one. Then you have the adenoid cystic carcinoma. Important things to look for in the H&P, mainly facial nerve paralysis, because this indicates that the tumor is invading the nerves, and this is an indication of malignancy. Mucoepidermoid carcinoma, they're most common malignant tumors of the salivary gland, affecting mostly the parotid gland. It's 5% of the salivary gland tumors. It affects minor salivary glands in 15% of the cases, mostly in 48 people of 40 to 50 years of age and female predilection. So more common in females than males. It usually has it could be either low grade or high grade tumor, depending on the ratio of epidermal cells to mucus cells. This would tell you if the patient are more likely. So low grade, they have a better prognosis, and they're less likely to spread or metastasize, whereas high grade tumors, they're more likely to metastasize distally. 75% of low-grade tumors, they have good prognosis. They rarely spread or metastasize, whereas high-grade tumors, they can spread locally or metastasize distally. They can metastasize both through lymphatic or hematogenous routes. Treatment is usually surgical excision of the tumor with post-operative radiotherapy. They're not very chemosensitive. Okay? And that's it for salivary gland tumors. If you have any questions, please submit them through Microsoft Teams. Thank you.